live streaming today from beautiful Durango, Colorado, and thank you to everyone who's attending both in person and online. We are here today to talk about MS with Dr. Andrew Wolf, and my name is Sophie Semenjik. I'm the Community Outreach Manager at the Rocky Mountain MS Center, and I would like to give a thank you to the pharmaceutical companies who have provided patient education support for this series. So thank you to Biogen and Genentech. This speaker series is just one piece of our educational programming. We have a variety of formats available to you, including both in-person and virtual education options, with most of our programs being on demand, available through YouTube. We just wrapped up our Spring Education Summit in April, and the archive is available on our YouTube. I highly recommend everyone check that out. Topics covered at the summit included research updates, brain volume changes, evaluating risk and benefits with medication, and MS progression. We announce all of our education opportunities through our mailing list, our Facebook page, and you can sign up through Eventbrite. All of our educational programming is free of charge to anyone interested. Now I would like to introduce Dr. Andrew Wolf. Dr. Wolf attended medical school at the University of Colorado, Denver, School of Medicine, and completed residency and fellowship at the University of Colorado. His research interests are focused on improving the treatment of patients with multiple sclerosis and other inflammatory diseases of the central nervous system. Current projects include developing digital and blood biomarkers to detect worsening in multiple sclerosis patients characterized by clinical outcomes of neuroinvasive West Nile virus infection in patients on anti-CD20 treatments. That is a mouthful. And understanding the risks of immune checkpoint inhibitor use in patients with neuroimmunological diseases. He is also interested in the acute management of demyelinating diseases and optimizing inpatient and outpatient care transitions. We had a lot of great questions submitted at registration, and we will get to as many questions as we can today. But you can ask questions again by typing them in the chat box or raising your hand. Today's presentations are for informal purposes only, and all decisions regarding MS treatment and medications should be discussed with your neurologist. With that, I will turn it over to Dr. Andrew Wolf. There you go.
Well, thank you everyone for being here. Just a little bit more background. So I'm an MS specialist neurologist up at the University of Colorado. So we have a pretty large MS clinic up there. I know some of you have been patients over the years. We have fortunate to be expanding our groups. So we'll be up to actually 12 of us total, depending on if you look at the adult and the pediatric side. So good group, have a lot of research opportunities and other things, but we're very happy to be closely linked to the Rocky Mountain MS Center for all these education and outreach events. But we appreciate everyone being here. So I wanted to go through all the questions that we had, and then of course we'll get a few that come up as we talk, and a couple through the chat probably as well. But first, something that just was going to provide some background for several of the questions that come back up is just about and often about age span changes with MS, and why and how the disease might look different over time. So it's sometimes helpful if we just have a diagram to help us understand that a little bit more. So I'm just going to draw on here real quick. And I did not make this thing follow me, so I need to do that. No. It worked so well on the practice run. So, all right. It'll be good. Okay. Okay. So if we think about our conceptualization of MS, what we're really thinking about is this is a longitudinal process, meaning that problems are going to develop over time for patients, especially if they're not treated or they're not on our current high efficacy treatments, which we've been very fortunate to have widely available, especially for the past 7 to 8 years. But if we look at this graph, so we think about disabilities, so neurological symptoms, being what we're trying to prevent and what will happen with MS over time, and then a time span of years. So, we used to characterize and still do a lot of the time people with something called primary progressive MS. So those patients will have sort of a very slow, but generally continuous onset of symptoms. And they may not notice anything over weeks, but if they're followed in the clinic for years at a time, or say 6 months, they might notice that some functions are going to get slowly worse and things are going to get more challenging. That's the minority of patients traditionally. Probably most of you that are MS patients were diagnosed with having relapsing MS, where you, at least initially, were having attacks of symptoms. So perhaps you were doing, normal, and then you had suddenly an explosion of symptoms. And maybe that remitted a little bit, where the symptoms reduced as that inflammation died down, but probably didn't go back totally to normal. And then maybe you had another attack happen at some point. And eventually, as there were more and more attacks, there was more problems that developed. We used to think of relapsing MS as sort of being static in between the relapses, where if you had relapses occur, you would develop those symptoms, but you wouldn't necessarily get worse unless you had another relapse. One thing that we've learned in the last, especially 5 years, is that that's probably not completely accurate. Is that there's this concept of people having progression or worsening symptoms from MS that have relapses, even if we put them on a medication that will stop them from having relapses. So we think that whatever biology is causing this primary progressive MS to happen, as far as the immune system, is probably actually also happening to some degree in patients that have the relapsing remitting MS. And I think the reason that that's really important is that it makes us think about definitely, focusing on drugs that may treat both of those aspects of the disease, which is not every medication. So every medication that we have for MS that is approved right now has an indication to be used to reduce the risk of having relapses. Not every medication has been shown to impact that progressive biology. And so those are drugs like Briumvi, which is ublituximab, or Ocrevus, Kesimpta. Those drugs are, more favored just as far as how they work to help with the broader spectrum of the disease. But we had a lot of questions about aging. So, if we think about back at this time point, just on average, our average MS patient in the US is going to be diagnosed when they're in their early 30s. Certainly you can be diagnosed much younger than that or much older than that, but the average age is about 30. If we think over time, one thing that we know is that the longer that you have MS and the older that you get, you're probably not going to have as many relapses. That is related to something that we call immunosenescence. So immunosenescence means that our immune system basically changes and often gets weaker as we get older. So especially in patients who are over 55 or over 65, we get less concerned about having those relapses as a worsening component. But that doesn't mean it's impossible, and there's some individual predictors there. But we get more concerned about this progressive biology still happening despite the age of the patient. The other contributing factor there always with age is that there's a lot of things that can make symptoms from MS get worse, as well as to have new symptoms that are neurological, that are not related to MS at all. And so you can imagine if you have really bad arthritis, that might impair your walking, but that's not MS related. It's not going to respond to MS medications. If you have cervical stenosis or some squeezing of the spinal cord in the neck, which is actually very common, that's another big reason that we see people have problems with their gait. And we think about all these comorbidities, so things like high blood pressure, sleep apnea, all these things that, if they're not treated, can damage the brain over time. And that's why we try to diagnose and manage all these things as soon as we can, early on in the disease. But I think that just is a helpful, hopefully, just conceptualization of sort of MS over the lifespan. So now we'll talk about a couple other questions related to that. Okay. One thing that was related to this is what are indicators of a patient progressing from relapsing remitting MS to secondary progressive MS? So again, that would be sort of a transition between having worsening from relapses to just sort of slowly getting worse from different types of inflammation. And so we hope that we have reduced the rate of this happening by having patients on higher efficacy medications. But the predominant predictors besides age and duration of time for developing secondary progressive MS are related to how many lesions patients have accumulated before they are treated and where those lesions are. So the biggest predictors for that from a lesion or injury standpoint are lesions that are in the spinal cord, especially in the cervical spine. Because if you think about it, especially for motor symptoms like moving your arms, walking, all of those pathways to control your arms and legs have to run through the upper part of the cervical spine. So we have a lesion there and it sort of slowly worsens over time. It's very hard for your nervous system to find another pathway to make those things work. If we were to pull up a brain MRI, there's a lot of places in the brain that we could have some MS lesions that you would not actually notice any symptoms, mostly because of redundancy and the brain is much larger. If you think about your spinal cord, just as a concept, it's probably a little bit smaller in diameter than your pinky finger. So there's really just not a lot of volume there for things to figure out an alternative route. So speaking of just lesion location, there was a specific question about trigeminal neuralgia. So for anyone who does not familiar with trigeminal neuralgia is a headache syndrome that is quite painful. So patients will often get shocks of like an electrical or burning sensation in their face. So the trigeminal nerve is a nerve that will impart carry sensory signals back from your face to the brain. And so for whatever reason, MS can actually attack the trigeminal nerve right at the location where it enters into the brain, something called the nerve root entry zone. And if you get an MS attack there because that myelin's irritated, the nerve can sort of short circuit and it can just be overactive and cause very frequent pain sensations. So that is MS is a significant cause of trigeminal neuralgia. Only a minority of MS patients, fortunately, will experience this, and they're probably ones that just happen to have lesions in these locations in the brainstem. But you can also get trigeminal neuralgia if you don't have MS, just for different reasons as far as the irritation of that nerve. And the vast majority of patients that have trigeminal neuralgia do not actually have MS. So, fortunately, there are a lot of medications that some of you may use for different reasons. So things like carbamazepine that can be used and hopefully control trigeminal neuralgia symptoms. So it definitely is treatable. I'll try it again. It worked so well before. No. Oh, wonderful. All right. Oh, sure. Okay. All right. Then we got a question about pathophysiology that says, what conditions are linked to MS and or made worse by MS, including both autoimmune and non-autoimmune diseases? So I'll answer the question from the autoimmune side. There's not a lot of diseases that tend to overlap with MS as far as risk from the autoimmune standpoint. The ones that we see relatively frequently are uveitis, which is an eye disease where there's inflammation in the eye, so that can overlap with multiple sclerosis. And then inflammatory bowel diseases, so things like ulcerative colitis and Crohn's disease. And there's some thoughts that there's some differences in how the immune system may work as far as how it presents some proteins, which is how your immune system communicates, that may lead to that increased risk. But the diseases are seen as an overlap in a very small percentage of patients. But most autoimmune diseases do not actually seem to overlap with MS, fortunately. Okay, and then since we talked about some background, we can talk maybe about treatments. So we got quite a few questions about disease-modifying therapies, so medications to reduce inflammation in MS and hopefully impact these processes. So the first question, I said, should it be an expectation that my neurologist stays up to date with the newest treatments for MS? How do I bridge a conversation without disrupting the relationship that I have developed over time? So very good question. If someone is treating you for MS, then absolutely they should be up to date on the disease-modifying therapies, as well as on any new diagnostics or symptom management, medications. So I think that's very, very important. So definitely, I would, if I was the patient, and as a neurologist, I would encourage you to bring that up. I think it's a good point. It's not always like an incredibly comfortable conversation to be like, hey, why don't you know about this? Or why haven't you talked to me about this medication? So I think it's usually, one way that's helpful that my patients will bring things up to me is they will just say, hey, Dr. Wolf, I was reading about MS, or I saw this video, or, even with our education sessions and things, hey, I saw, this drug mentioned at the Rocky Mountain MS Center education event. Like, what are your thoughts on it? I don't think anyone's going to get upset with you about that. I mean, they certainly shouldn't. Just to try to open a dialogue about what may be the pros and cons of a medication. So that would definitely make sense. And then if you feel like you're not getting, anywhere as far as getting more information or having other treatment options considered, then it's definitely worth getting an opinion from another neurologist. And especially if you don't see someone who specializes in MS, coming to our clinic or going to somewhere else, whether that's in Albuquerque or somewhere, that would be potentially good options for you. We do not do this, but there are quite a few places nationally that will also do like second opinion remote consults. So like Cleveland Clinic, for example, being one of them, where you can submit, and this is often covered by insurance, but you can submit your medical record and imaging, and they'll actually like review your case and how things are going and tell you if the course of action is reasonable. So from a geographic standpoint, like coming to Denver is not workable. Like there are some ways to get additional opinions that way. But definitely, worth pursuing if you're not, comfortable with the medication that you're taking. We got a couple of questions specifically about Ocrevus, which is ocrelizumab. So that's one of our drugs that is an infusion. So that drug is very effective. It's been out since 2017. It's going to work by reducing inflammation by killing B cells, which are a type of white blood cell. So it's an every six-month treatment. We're asked how many Ocrevus infusions have to be taken before someone can move normally again. I think that's a little bit of a challenging one to answer. So, we think of Ocrevus as being very effective at stopping relapses and worsening from having relapses. We think of Ocrevus as helping slow down the progression of MS. We often do not see that patients actually, get better from their initial symptoms when they're on Ocrevus. And that's true of all of our MS medications. So usually they're going to focus on stopping people from getting worse as opposed to improving the old symptoms. Although sometimes, especially if you've had a whole bunch of relapses and you're not on treatment, and then we put you on Ocrevus, just as that inflammation dies down, there may be some improvement just as your brain's able to sort of reset a little bit. Then we got a question about infusion reactions.
Dr. Wolf, can you just talk briefly about the class of DMTs that Ocrevus falls into? We had a question about what are your feelings about Briumvi?
Yeah, so we we have 4 drugs that are what are called B-cell depleting therapies. So we think about our immune system, one of the types of white blood cells that is misbehaving in MS is called the B cell. So the B cell, we've had different treatments to try to manipulate the B cells or kill the B cells for a long time. The very first B cell depleting drug that was used for MS is a drug called rituximab. Rituximab was invented in 1997. We still have patients that are on rituximab. For fairly complicated financial and legal reasons, rituximab was never approved by the FDA specifically for MS. Ocrevus, ocrelizumab, was made and came out in 2017. That was the first B-cell depleting drug that was approved specifically for MS. And then Kesimpta, which is ofatumumab, which is a monthly injection drug that came out in 2020. And then for the last 2 years, we've also had Briumvi, which is ublituximab. So these drugs are not exactly the same. They have different molecular structures, but they all work on the same mechanism where they're trying to kill these B cells that are overactive and causing inflammation in MS. So there may be, ultimately, if we follow them for long enough, some potential differences as far as their safety and their efficacy. But at the moment, the big distinguishing factors are a couple, which is, which one does your insurance favor as far as paying for it? And then which route of administration, works best for you as the patient. So they're all a little bit different from that standpoint if we focus on the 3 that are approved by the FDA for MS. Ocrevus has been given as an intravenous, so an IV infusion every 6 months. Recently, there is also another version, which is one of the faster ways to get an MS treatment, which is called Ocrevus Zunovo. So that is an infusion that goes under the skin into the abdomen that the drug can be given over 10 minutes as opposed to a few hours for the IV infusion. So potentially a little bit more convenient for patients. Kesimpta does not require getting an infusion. So Kesimpta is the drug that is given as a home injection 1 time per month. So if any of you have used an EpiPen before, Kesimpta comes in an auto injector, kind of like an EpiPen. So for patients that are not, afraid of needles or have the capacity to do that, it can typically be given in about 5 minutes a month just at home. And then Briumvi is every 6-month IV infusion, but it's typically given in a rate that's much faster than Ocrevus. So that, typically in about an hour, that drug can be given. So there's some differences there. There are some theoretical reasons that some of these drugs might work a little bit differently with different aspects of the disease, but none of that has been proven. So when I'm talking to patients, we tend to make decisions based on these convenience factors predominantly, as well as the insurance. So speaking of that with Ocrevus, so the question was really just about infusion reactions. Ocrevus it sounds sort of funny, but all these drugs are antibodies that are made in the lab. So they have different parts of the drug that will look like they're coming from a mouse, for example, just because it's how they're made. So you can get an immune system response to the drug itself, just because your immune system sees the antibody and it says that doesn't look normal and it wants to attack it. So people can get reactions like itchy throat, dizziness, vomiting, fevers, just from getting the drug. I don't want to scare anyone off from taking them. They're typically very well tolerated, but you often don't feel great like the first time that you're getting it. And then the very first time you're also killing all those B cells, and when they die, they release their signaling chemicals, and that can also make people feel a little bit funky. So people are having infusion reactions that are persisting over time, again, like fevers, itchy throat, shortness of breath, things that are helpful, are potentially modulating or slowing down how fast the infusion is given, or ramping up some of the medications that most of you that get infusions are probably getting when you get an infusion. So things like steroids, IV fluids, Benadryl, Tylenol, things like that. And those are just supposed to help your body tolerate the medication a little bit better. Rarely, if I have a patient that just still can't tolerate an infusion, we'll just try one of the other drugs in that class because sometimes they will feel a little bit better if we say switch from Ocrevus to Briumvi or vice versa. Okay. Then we had a question about, do these B cell drugs, they seem very effective in halting or limiting relapses. If using them, does that efficacy tend to wear off over time? And I would say no, there's not been any evidence of that effect wearing off over time. For Ocrevus now, just because the clinical trials started about 10 years ago. We now have published data for over 10 years of use. And then, thinking back to rituximab, like we started using that drug off-label for MS in about 2008. So we've had patients that have been on that for about 15 years and have not, nor would we expect to see the drugs to wear off.
Okay. Dr. Wolf, we had a question online. This person is specifically asking about rituximab, and they were told that after 10 years, they would have to stop the therapy.
So there are, with any of these B cell killing drugs, there are some risks of use that seem to accumulate over time. And that's mostly because as they kill those B cells are not working normally. And you can have some reduction in some other functions of the immune system. This tends to happen in a small percentage of patients, especially over the 5-year range. But something called an IgG level, which is an antibodies that your body makes to fight infections, can drop. And so we frequently are monitoring that in our patients every 6 months, just so we can get an idea of the trajectory. By no means is there a hard stop as far as like there's some time point that you can't take these drugs anymore. It's going to be individualized. Like if you have not had any infections and your blood work looks great and you're doing well and you've been on rituximab for 10 years, there's really not a reason to stop it, just solely based on that arbitrary time point, at least from my opinion. People may not need to be on the drug, or they may not to be on it quite so frequently as they, just based on how the drug works, we might be able to give it less frequently over time. But that is not entirely a proven strategy. There's actually a couple clinical trials specifically for rituximab in Scandinavia, so in Sweden and Denmark, where they use a bunch of these medications to look at, could we give you rituximab every 12 months instead of every 6 months? And would that be an equally effective but safer strategy? There's a little bit more still to learn from that standpoint. Okay. Then we had a question, a few that are sort of interrelated here, just again about aging and treatments. So if we think about, back to just the concept of MS over time, you may ask the question if the relapses are not going to happen probably as much anyway as you get older, would you need as powerful of a medication to try to stop relapses or not? And I would say in general, we expect that a lot of the inflammation in MS changes over time and there's less risk of relapses, but perhaps more risk of the progression of the disease. The drugs are going to work really well for relapses. The drugs, tend to help with the progression, but they're not quite as good. And we know that the risk of the drug is probably going to go up over time, both based on how long people are on the medication, and then also because as people get older, they have more other health issues that will predispose them to getting sick. So we worry a little bit about immune suppression because of that. Most of our MS clinical trials have not done a good job about studying older patients. So they're typically going to have a cutoff at age 45 or age 55 as far as an upper limit of who can be in the study. So there are not any clinical trials specifically looking at, hey, let's put this 65-year-old patient who's getting worse on Ocrevus, like that, that study has not been done. So it becomes a very, individualized decision. if people are stable, they're not having any relapses, they feel like they're not having any progression, there's not on medication, they haven't had a relapse in a long time, we don't necessarily have a huge push just based on that risk-benefit argument. But if people feel better on the medication and it's being used safely, there's not a lot of data telling us that we should take it away. If there is a push, either from a convenience, a cost, or a side effect standpoint, to stop a medication in an older patient, we actually have quite a bit more data over the last couple of years that can be a useful strategy. And so John Corboy, who's one of my colleagues at the University of Colorado, completed a large study called DISCO, so like discontinuation of MS therapies. And so that study was taking patients who on average were 65 years old and they've been stable for 5 years. And it said, hey, if you're stable for 5 years, you're 65, let's either take half of you and have you keep your medications or half of you and stop the medications. And the rates of having any relapses, MRI changes, or worsening from MS was very low in both of those groups. But that doesn't mean that we're just going and taking the drug away. Typically, there is going to be some impetus for us to do that, like the patient has a lot of side effects, either things like infections or they're on an injection therapy like Avonex, for example, and they just feel crummy when they take it. So again, it's a very personalized decision. Okay, I've got a question specifically about research studies. So for primary progressive MS and secondary progressive MS. Again, like these are very active areas just because we've not had as much success in that progression or slowly worsening treatments as we have had with relapses. There are, we'll talk a little bit just about some research that has been finished. So we expect to have a medication likely to be approved by the FDA for at least for secondary progressive MS at some point, either the end of this year or early 2026. So that's a drug called tolebrutinib. That drug works on the B cells that we talked about. It also works on some other types of inflammation. That drug, is not a home run, but it does look like it works in slowing down some of the inflammation. So the FDA is set to review that medication's application in September, and we'll see, once all that data is there, what does the safety and the efficacy look like? But I do expect that based on what's available for that drug to be approved eventually. As far as active studies, we have a few studies for secondary progressive MS at the university that are running at the moment, but are not recruiting, so we can't take new patients. And then similar for primary progressive MS. And then we have a couple secondary progressive MS studies that are still recruiting. So one of them is for a medication called frexalimab. So frexalimab is a treatment that is supposed to work on a few different aspects of the immune system and hopefully reduce both the relapse risk and some of this progressive worsening with MS. It did look like it had pretty good data in what's called a phase 2 study, but we never know for sure until we do the confirmatory trial, which is a phase 3 study, and so that is what is ongoing. The other thing that you may have heard about, I know we've had some talks about it with the education summits, is something called CAR-T. So CAR-T is being explored for both relapsing and progressive MS. And so CAR-T sounds a little bit like science fiction, but CAR-T has been used for quite a while now for cancers, and it's been quite effective. But it actually does a really fancy blood draw called an apheresis. It takes and separates out the T cells, so another part of the immune system. And then your own T cells are then modified in the laboratory so that they go in and kill all of your B cells. But they do so in a way that we think is more efficient and more effective than with our current B cell drugs like Ocrevus or Briumvi. So CAR T has been used, like I said, for 15 years to treat cancers that involve the B cells. It's been very, very effective. It's been used in a couple small studies for other inflammatory diseases. So diseases like myasthenia gravis or lupus, and it looks like it's effective. But we're just having the earliest studies happening for MS. So we are a site for, at the moment, for one CAR T study up at the University of Colorado, specifically for MS. And then one other study for primary progressive MS that we are trying to get started is actually looking at doing bone marrow transplantation. So similar, again, to what someone would get if they had a cancer like a leukemia, could we basically deplete or kill the entire immune system and then restore it and have it not have the same problem that it does with MS. And so that has been done actually quite effectively for relapsing MS. We know that stem cell transplant works for that condition, but we've not been able yet to prove that it works for primary progressive MS. So we're hoping to gather a little bit more data on that as well.
Dr. Wolf, a couple of comments while we're on progressive MS. I was told that Ocrevus is the only approved treatment for primary progressive MS. Is that true?
Yeah, so technically that is true, yes. Ocrevus is the only drug that did a phase 3 trial and was approved specifically for primary progressive MS. We sometimes, at least I will, and I think everyone else in our center will sometimes use the other B-cell depleting therapies, so like Kesimpta or Briumvi, if there's a very specific reason that the patient wants to use those, but Ocrevus does have the best evidence.
And then can you go into any more on stem cell therapies, briefly kind of the difference between why it might help relapsing, but we're unsure on progressive?
Yeah, the short answer is we're not sure why. It probably relates to what type of inflammation we're actually impacting with the stem cell transplant. So if you think about most of the disease, as far as the relapse-related inflammation in MS, is actually not living directly in the brain. It's actually flowing in from like your lymph nodes and the rest of the immune system. For progressive MS, we think that there's a lot more problems, with the immune system that's specifically hiding out in the brain. So with things called microglial cells, for instance, that we don't necessarily know at the moment that the stem cell transplant or any of our drugs are going to fix that. One thing with the transplant studies for progressive MS that are going to be different is that they're going to be what are called an allogeneic transplant as opposed to an autologous transplant. So we think about stem cell transplants, like if I had a leukemia and I needed a stem cell transplant, typically what would happen is I would get a whole bunch of chemotherapy that would hopefully kill all of the leukemia, and then they would have saved some of my blood cells. They would give me my own blood cells back, and then my immune system would regrow over time. But the leukemia would not be there. You can imagine the issue with that from the MS standpoint is we don't really totally understand what causes MS to happen. So if you give me my same white blood cells back, it's possible that the same problem or predisposition to have MS may still be there, and I may just develop MS again at some point in the future. So one of the newer studies is going to focus on doing what's called an allogeneic transplant. So that's actually getting the immune system donated from another person. And so historically that has not been done just because that has a lot of risk as far as something called graft versus host disease, where if I took Kelsey's immune system and gave it to me, even though that might fix the cancer or help with the MS, my immune system then forever would be like fighting back against that immune system. And then that immune system would be fighting my own body. But there are some newer techniques that have been used in cancer that or reduce the risk of that graft versus host disease happening. So we would like to do a study where we use those same things to do a trial in MS, and that is the plan, but not quite up and running at the moment. I had a question that just was about something called C15 and myelin. So C15 is a chemical, also called pentadecanoic acid, which is part of myelin. I couldn't find a lot about this as far as could taking like this chemical help with repairing myelin. So theoretically possible, but we don't have good evidence about that. I think, despite the success that we've had with all of our inflammatory-based treatments for MS, we have still really struggled with therapies that may help with remyelination or fixing the problems from MS. It's not that we're not trying, it's just that we've not got a lot of traction. There's been a lot of studies looking at things like biotin, statins, stem cells, all sorts of different products. We just have not found one that has been reliable to work and also safe, but we certainly will keep trying on that. Okay, and then there's a couple questions about just more so like infection and vaccine related stuff. There was one comment asking about MS and West Nile virus, which is something that we're really interested in actually. So West Nile virus is a virus that is spread by mosquitoes. It's actually fairly common in some parts of Colorado and Arizona, but West Nile virus has been in the US for about 25 years. Historically was infecting people in Africa. Most patients that get West Nile, which the season is coming up on us, so it's typically the summer to early fall. Most people don't get symptoms from West Nile. A very small percentage of patients will get neurological symptoms, so like from a meningitis, so like headaches, and then rarely people can get injuries to the nerves or the spinal cord from West Nile. Unfortunately, that's not very common. I think why this comes up with our MS patients is that those B cell depleting drugs, so rituximab, Ocrevus, Briumvi, Kesimpta, seem to have a substantial increased risk of having a lot of problems come up if you happen to get a West Nile infection. I typically do counsel my patients just to be careful about typical techniques if you're going to be outside to avoid mosquito bites. So that's long sleeve clothing, mosquito repellent, that sort of stuff. It is still very uncommon, but it can make people quite sick if they get it. So we actually did a study of our patients just in the UC health system that we recently published looking at this. If you do get West Nile, it does tend, if you happen to get it, does tend to lead to people to be in the hospital and have some new symptoms and problems that will persist at least for a couple months. And then there were a small number of patients that actually died from the infection. So just really something to keep on the radar. I certainly would not let this stop anyone from using Ocrevus, but I would just say if you're on that drug, just be careful about being outside in the summer and early fall. Then there was a question about vaccines. So I think it's important to get vaccines and to plan ahead for vaccines if you're going to be on an immunosuppressant. I think even more so than if you're just someone without being on these drugs that's walking around. And so, part of that is based on how the medications work, is that they're going to suppress the immune system. So if we, want to reduce the risk of infections, having a vaccine on board is going to help do that. So whether that's a flu vaccine or a COVID vaccine. And then there's some more specific ones. So we know that a lot of our MS drugs, so those B cell therapies, and then some of the oral medications like Gilenya, will also increase the risk of getting complications like shingles. So shingles is when you have had the chickenpox virus, varicella, and it can reactivate and cause a very painful rash, among other symptoms. So trying to get a shingles vaccine that can reduce the risk of things like that happening. But those are ones that we often try to focus on, as we're planning out treatment for patients, just to make sure we get them on the correct vaccines. I think the second part of the question was more, I think, related to risk of vaccinations on the treatments. And so that is going to be really specific to the specific treatment that we're thinking about. If anyone's on any immunosuppressive MS medicine, which is almost all of them, we get really concerned about live vaccines because vaccines come in a couple different flavors. So live vaccines are when we're actually giving you like the virus. We've just weakened it. So then if your immune system is not working normally, it may not be able to kill the virus like it should, and you might get very sick. Whereas if we give you a weakened flu virus, for example, and you're otherwise healthy, you're just going to feel maybe some very mild symptoms, fight it off, and then get the benefit of the vaccine. So there's not a whole bunch of live vaccines anymore that you would typically be getting as an adult. So the ones that are still used, especially in childhood, so polio vaccine, the MMR vaccine, yellow fever, which sometimes comes up for people that are traveling, and then the chickenpox vaccine. I think most of us, if not all of us, were old enough that we got chickenpox the original way, but there is now a chickenpox vaccine that's a live virus. So you should definitely not get that. Like, one, you probably don't need it, but that would not be typically a safe thing to do if you were on an immunosuppressive drug. There was a question about travel. So if you're at all curious about like, hey, what vaccines do I need, before I go somewhere, and how does this relate to MS therapies? The Centers for Disease Control usually has a good database to look at, where if you type in "I'm going to Japan," it will tell you like what vaccines might be recommended. Then it's usually just worth checking with your doctors as far as both the timing of the vaccine, and then make sure this one would be safe to get if you're immunosuppressed. None of the vaccines, as far as we know, are going to cause a risk of like the MS itself flaring up. It's mostly about the safety of giving like a live vaccine if you're immunosuppressed.
We had another research question. Can you discuss any progress on remyelinating strategies generally, and then also specifically about the over-the-counter allergy drug clemastine?
Yeah. So the remyelination, like I was saying, has been a challenge as far as a lot of studies, but not a lot of progress as far as things that have been shown to be helpful. One drug that is not has not sort of completed its studies is the drug that is mentioned, which is clemastine. So clemastine is an antihistamine drug. It was looked like in the laboratory it may impact our brain's ability to make myelin. Again, what's being damaged with MS, at least one of the things. Clemastine has completed a couple small studies. The biggest one specifically for optic neuritis, where the nerve from the eye to the brain, which can be often impacted by MS, was irritated. And in that study, it did look like treating with clemastine improved the speed of how well that nerve worked. So you can imagine if you do not have the myelin working normally, it's sort of like if we stripped this cable of its insulation, this electricity would not conduct as well. So clemastine did look like it sped that up. It was a fairly modest benefit. And so typically we get some kind of readout like that. And when we say, let's do a larger study where we then look at how well can people actually see as opposed to measuring the speed. So that study is still happening. I think we have a handful of patients that we had considered trying the drug, saying it's generally a safe medication. It's just an antihistamine, before that was approved, just if they were really interested in it. There's been a little bit of hesitation for that because there's been a few smaller studies in the last year to 2 years that have had concerns that patients going on clemastine have actually gotten worse in other domains. So like with walking, for example. So at the moment, especially because that study is in progress, I think most of us are saying, let's just pump the brakes and wait and see what we see as a final outcome. Okay. We got several questions just about symptom management. One question just overall says, are there any new medications that work to help with MS symptoms? The answer to that as far as specific drugs just for MS symptoms is no. So we don't have a whole bunch of drugs that are approved specifically to treat MS symptoms. The one that we do have, which has been out for about 15 years now, is Ampyra, dalfampridine. So that is a drug that can sometimes help a nerve that has been injured and demyelinated to work a little bit more efficiently as far as how it conducts electricity. So that was studied in patients that had walking difficulties from MS, and it helped about half the patients walk faster. But that is still the only drug that's really targeted to MS symptoms. But of course, there's always evolutions in medications that are used for the other symptoms that patients have. They're just not specific for MS. So, for example, in my clinic, like we have tons and tons of patients that have migraine headaches, for example. We know that migraine headaches are more common in patients that have MS than in people who do not. So it's an important thing for us always to help with. The migraine treatment landscape has totally changed in the last 5 years. Even when I finished medical school, there's like 10 new drugs that are out that we did not have before, that are either equally effective or more effective and much better tolerated than the old school migraine medications. And the probably less changes, but there's also always things that are happening as far as medications for bladder control or nerve pains or things like that. It's always worth talking about, just making sure you're up to date with your neurologist on the most recent things. Got a question about the best way to address chronic inflammation and fatigue. I think with fatigue, very, very common MS symptom. We don't know exactly why fatigue happens. We assume that part of it is just related to the brain networks, just not communicating as efficiently as they would if there was not the lesions from MS. So I typically break this question down a little bit in clinic to is that the only problem, or are there other things that are happening that may be indirectly related to MS that are also relate to fatigue? So ones that we think about, so medications. So although they work well for nerve pains, certainly if I put someone on a tremendous amounts of medications like gabapentin, they're going to be more tired. So we should always make sure we're having a balance between the symptom management and the side effects. Two, and probably the biggest one, is sleep. So we know that there's an increased risk of sleep apnea in patients with MS. We should always be thinking about that, diagnosing it, then potentially treating it if it's seen, just because that can often be, like a total 180 in fatigue symptoms if that's a contributing factor. Another big one is mood symptoms. So if there's depression or anxiety, these are also things that are much more common in MS patients. Are we treating those things adequately enough and making progress where we can limit that impact? And then things like lifestyle changes, like diet and exercise. So we know there's some data for actually being more physically active can help with MS fatigue, as well as some specific dietary habits. Like the Mediterranean diet, which is more fruits, vegetables, less processed foods, and whole grains. There's been some studies that show that there's a benefit of that with fatigue symptoms as well. Second part of that is, if we do all those things, there's still a lot of fatigue. We will often try medications targeted at that. We just don't have perfect evidence as to how well they work. So as opposed to RRMS, immunosuppressive drug studies, we do not have as much data or really any confirmatory data that fatigue medicines are going to be helpful. Having said that, I have hundreds of patients that are on them, and a lot of them feel like they're helpful. And so personally, the meds that I typically think about in that context are drugs that are going to basically increase the levels of some of the chemicals in the brain, including dopamine, and norepinephrine, but the ones that we use typically a lot of are like modafinil. So that was a drug that was invented to help with fatigue for patients with sleep apnea. It's an oral medication. It's often worth a trial. Okay. There's a question about heat, so that's gonna, of course, be coming up. So how to control the heat and how it affects symptoms. So this has been known for a very long time, is that MS symptoms are going to get worse with hot weather or changes in body temperature. So, for those of you with MS, and you've even had a fever from like having the flu, I'm sure that you realize that, you feel quite a bit weaker and worse, when you're not feeling well. And that and just the heat sensitivity in general is actually very well explained by some of the physics of how your nerve cells are working. So the electrical patterns in the nerves will actually change based on how different chemicals like sodium and potassium are moving in and out of the cell. And that can change dramatically just based on your body temperature. So way back before we had MRIs, sometimes one way that would be helpful to look at patients with MS is people would get an exam and then they would literally like sit them in a hot water bath and then re-examine them and see if they got worse or not. And typically they would, just based on those reasons. So there's a few different ways to approach this. There's not a cure-all. One way is to try to modulate your environment. But we do have patients that are on programs like with Excel Energy, for example, where they can get reduced electricity rates if they qualify to pay less money, like in the summertime, just because they're using more air conditioning. We have a lot of patients that will use cooling vests to try to keep their body temperature down. So just with ice packs or cold water. We don't have great evidence for this, but if it's really bothersome, I'll often try it. Is that medication Ampera that we mentioned for walking, just because it changes how some of the nerve cells work. Sometimes we'll try it for patients if they're really bothered by the heat sensitivity and see if it's helpful. But we don't have a total home run fix for that at the moment. It can certainly be a quite annoying symptom for our patients. Okay. I had a question about foot massage or just massage in general. Can that help with symptoms? The answer to most of these things is actually yes. So we don't, again, have amazing studies like we do for the medications, but there is a lot of data for some of these more complementary medicine techniques like acupuncture, massage therapy, yoga, that patients will see benefit both with motor symptoms and then also with things like fatigue and pain control. All of them typically are quite safe. So they're usually worth considering if it's something that you have coverage for or able to pay for and you think it might be helpful. There's a question about non-medicated, what non-medication recommendations do you have for dealing with muscle pain? So again, those things that I just mentioned, and then some physical activities can sometimes be helpful. The one supplement that I will recommend a lot to help with like muscle cramps, for example, is magnesium. So magnesium can often be very helpful with spasticity, so like tightness and muscle spasms. Magnesium is very easy to take. It has very few side effects, and you can typically buy it for like $3 a month. We use a couple different types of it. So magnesium comes in a few different forms. So magnesium oxide or magnesium glycinate are typically very well tolerated. You can also buy magnesium citrate. That is more of like a laxative, like people will take that before a colonoscopy. So that's probably not like the good one to take. But oxide is probably the most common one that is out there, and it can sometimes be helpful.
What action or medications would be used for treating cold sensitivity?
Good question. I think, we often would think about the same things as far as environmental modulation. And then I have tried Ampera before just for any swing of temperature sensitivity. We don't understand quite as well like why that would be a symptom that patients have, but I will say, probably half my patients don't really notice much as far as temperature. Of the half that do, probably 80% of them do poorly in the hot weather, but definitely being that we experience cold weather in Colorado, the other 10% of that total group sometimes is just very cold sensitive.
Any questions in the room?
I might have one question for you. I have a loud voice, so usually I'm pretty good. I had a question for you on metformin. I've seen recently that there are studies that say metformin might help with MS. Are you aware of that?
Yeah, so that's a good question. So I think if we break that down a little bit, so the thoughts are sort of twofold. Because this has recently come up for statins as well, so like Lipitor, atorvastatin, simvastatin, the cholesterol medications. So, part of the thought with these is that, we know that the prognosis of MS is going to be worse the more other health issues that people have. Maybe that it doesn't directly impact the MS, but just that there's more damage to the system just from having, like diabetes or what have you. So metformin's been used for a long time as a diabetes medication, pretty safe and effective drug. The thought was that it also may have some other benefits to the metabolic health and reduce inflammation, totally separate from what it's doing to the blood sugars. It certainly has shown some benefits in animal models. So like with mice, for example, the challenge with that is that we probably like cured MS like 5,000 times in mice, and we certainly have never cured it in humans. So we're always a little bit skeptical. And so that's why we have to do the human studies. And so there are studies right now that are running, not completed, but will help us answer this question, to look at metformin as like an add-on therapy. So I say like, let's keep you on your MS drug, but we'll also give you metformin and see if that group does better as far as how well they feel. We had this similar thing completed for the cholesterol drugs with statins. So there was some evidence that even separate from the cholesterol benefits, that statins may actually reduce inflammation and help with MS in addition to whatever more traditional drug the patient was on. So that study finished up about a year ago. Was a very well done study that was run out of England. Unfortunately, did not work at all. Like the groups were like literally exactly the same. So that one we sort of have given up on, but yeah, we'll keep trying these other ones that look like they work. And the advantage is that, we know so much about metformin because like 100 million of patients have been on this drug. So we have a very good understanding of the side effects as opposed to some brand new medication.
Are there any supplements like vitamins or gummies or whatever that are not recommended to take?
Good question. So I'm gonna back up a little bit and we'll talk about which ones are recommended to take. Which the one that has by far the most evidence and we recommend is vitamin D. So we've been giving people vitamin D for MS for a very long time, and that was mostly related to some studies that showed that the risk of getting MS was higher if you were deficient in vitamin D. It's been harder to prove that the vitamin D level being low actually made the MS worse or more active as far as relapses. Vitamin D is very safe to take as long as we don't give you crazy amounts and we monitor the level to make sure it doesn't get too high, because you can get toxic on vitamin D, especially if your blood levels over like 100 or 110. So we typically shoot for like 40 to 80 as our goal range, which is a little bit higher than the normal range, which at least in our lab is about 15 to 60. But the reason there's even more interest in vitamin D is that there was a study, a big clinical trial completed, again, within the last year in France. And so that took patients that were newly diagnosed with MS. And just based on the treatment patterns of using drugs in France at the time, like none of these patients actually were put on an MS specific medication. And it took all those patients and it found all the patients who were low in vitamin D. And then they took half of them and they said, we're going to give you high dose vitamin D and we're going to look at how good you do. And they took half of them and said, we're not going to do anything and we're going to see how well that you do. And even that intervention with fixing the vitamin D level to get it back into that higher range looked like it actually worked about as well as some of our very old school MS therapies. And vitamin D, as long as we monitor it, is very safe. And it, again, it costs a couple dollars a month, so it's really like potentially a valuable, intervention there. Other supplements do not really have as much data. So there's a few things that sometimes we'll check for neurological symptoms. So like vitamin B12, for example, there's not really a link directly between MS and like having low vitamin B12, but vitamin B12 can certainly cause, if it's low, symptoms that will sort of overlap with MS symptoms. So we'll often check that one if there's certain things that we might be concerned about and then supplement it. We don't typically recommend a lot of other ones. The only one that comes up that we typically will get concerned about is vitamin B6, which is pyridoxine. So vitamin B6, people certainly can be deficient in, but the bigger issue is that you can actually get toxic and damage your nerves from taking vitamin B6 if you take a whole bunch of it. And it sometimes is a little bit sneaky. So like if any of you drink like certain like energy drinks, like they often have like absurdly high amounts of vitamin B6. So I've seen sometimes some patients that come in and their levels very elevated. But most other supplements, tend to be safe, we think. We just don't have a lot of evidence that they're helpful.
Does the Rocky Mountain MS Center take Medicaid?
Absolutely.
Thank you.
So I'm wondering, I think I'm primary progressive and my progression is pretty steady, like it hasn't ramped up or anything recently, but it's been a really long time since I've had an MRI. Is there any reason to be getting MRIs on like a regular basis just to check things out, or does it not make sense if you don't have new symptoms?
Yeah, I think you could probably ask all 12 of us at the MS Center what we thought about that, and you probably would get at least 12 different answers. Sometimes I feel like it fluctuates based on the day. So MRIs are very valuable tools for diagnosis. MRIs are very valuable tools to evaluate new symptoms that are happening. Is it from a new lesion that shows up from like a relapse? Does it look the same as something else happening that's not even MS? So for our patients early on in the disease, we're often getting MRIs every year. We sometimes do them more frequently if there's new symptoms that are happening. For patients with progression, we're sure they have MS. They've been stable for a long time. We often will back off, at least I will back off a little bit about how often I get MRIs, just because if there's progressive disease, we don't always see changes on the MRI, like even if things are getting worse. And so that's actually probably one of our big limitations at the moment is, even if people are getting worse with progressive MS, we don't always see a corresponding change on the scan. And probably what's happening is there's more injury happening either everywhere in the brain that's not like a focal lesion, or that the lesions that are already there are just having a different pattern of inflammation and causing more injury as opposed to them multiplying. And so I typically don't say let's never get an MRI again, but I often will start to space them out a little bit if things are stable to like every 2 years. Yeah, but certainly if there's ever like brand new symptoms that are happening, like I would definitely get an MRI. I think I had 2 other questions on here. So one was about something called a PEMF mat, which is like basically a rehab technique that tries to use like forms of electrical stimulation to try to help with symptoms. So when I was looking at this, there is just a smidge of evidence on it from a study that was about 20 years ago that I saw. I didn't see a whole lot of new stuff on it. So I would be a little bit reluctant about it just without a ton of data, but it's theoretically possible that it could be helpful. And then the other one was just talking about balance and stiffness issues for someone that takes Ampira and then baclofen. So we do have a lot of other medications that will help with spasticity and muscle stiffness that are not baclofen. And then we also have different ways to get baclofen depending on how people are doing. Like a baclofen pump, we actually get the baclofen delivered directly like into the central nervous system. But medications like tizanidine, for example, even medications like gabapentin can also be helpful with some of these symptoms. So if there's a question as to like they're not working well enough, it's definitely worth talking to your doctor about.
We also had a question about immunotherapies, and I know you touched on CAR T, but is there anything else you can say about the effect that immunotherapies have on MS?
Yes, so there's sort of two ways to look at this. So we have the immunotherapies that are like trying to use the immune system to treat the MS. So we will have some other types of like products similar to CAR T that will be coming as far as things to look at. And then there's another class, sort of similar medications that are called bispecific antibodies. So those are supposed to help your T cells like recognize inflammatory cells and kill them. Again, we like to steal all of our ideas from the cancer doctors. So those have been used for like multiple myeloma for quite a while now and have been very helpful treatment strategies, but not any study immediately for MS that is recruiting. The other, it's a little bit more of a nuanced question. The other thing that has started to come up a lot is that there are immunotherapies that are used for other diseases, and would those be safe for patients with MS? And so we have learned over time that we can actually do things to the immune system that will allow it to go fight cancers, even without something called CAR T. So there's drugs called checkpoint inhibitors. So those are drugs that will basically, remove a brake on the immune system, and it can cause your immune system to be much more active. And part of our immune system's job is to fight infections, but part of it is to also fight any cancers that may be developing in our bodies. So these checkpoint inhibitors have actually been very effective for treating things like melanoma, for example. So there's been a lot of concern, because these cancers are fairly common, about, well, what if you already have an autoimmune disease? Like, could we give you this checkpoint inhibitor drug, which are drugs like Keytruda, pembrolizumab, or would that be too dangerous? Would we give this to you and you would instantly have like a flare up of the MS and like it would not be worth trying, despite the cancer? And so we're still developing data on this. We have been a part at the University of Colorado of a few studies now looking at this along with some other centers across the country. And so, it looks like for most of the patients, the risk of these checkpoint inhibitor drugs causing a flare-up of MS is actually quite low. Now, the one stipulation that I have with that is that, again, this has to be a bit of a personalized decision, because if there's some other treatment for the cancer that might work just as well, we probably would not want to use these medications. And also just given given the cancer, a lot of these patients were older and had less active MS. We have very little data, like let's say, you're 30 and you get a cancer, you have MS, and we want to give you one of these drugs. Is that actually safe or not? So we're doing some larger studies looking at that. At the moment, it's a little bit nuanced. We have a lot to learn about the immune system overall.
Have you heard anything about Semaglutide showing promising results in remyelination?
About semaglutide. Yeah, so semaglutide, these are the GLP-1 drugs. So these are the drugs that have been pioneering for helping with weight loss and then with blood sugar management. So the thought is that they may also have a lot of other effects that are positive on like the blood vessel and inflammatory health. So there's not yet been a study in humans on specifically looking at these medications for myelin or for clinical outcomes, but definitely something that's very, very interesting. And I would be very surprised if we did not have clinical trials for these medications in the next couple of years. Oh, and they are safe to use. So we would not expect a reason for them to cause a problem with MS in the accumulated data from patients that are, say, getting them for diabetes control, but also happen to have MS has not demonstrated any concerning findings.
We have time for just a couple more questions. Do we have any more in person?
One of the questions I have is, you state that there's really not a whole lot of study group when you're over 70 years old. In other words, none of this is being studied. So if you're a patient that has MS for 30 some years and basically therapy is stopped, is that it? I mean, I know that's kind of a hard question, but I mean, we can't reverse things, can we, at that age? And then what happens? I mean, why no study groups in that age, I guess.
Yeah, is a great question. So I would say this is probably, first of all, is not necessarily an issue that is unique to MS as far as populations that are focused on. So there's a lot of disparities elsewhere where we don't see a good representation of our population. So like just with our aging of our population in general, we have more and more patients that have MS that are over 65, right? Similarly, we don't see really good involvement outside of a special study that was fortunately done with Ocrevus for like minorities that have MS, so or people with different socioeconomic backgrounds, right? So like if you look at some of our older MS studies, like literally like less than 1% of the patients would be African American as far as identification, which is like drastically different than our overall population. Part of the issue, with age is based on trying to look at groups that have probably a better chance of having success. And so like the cleanest population to look at if we're designing a study as far as is a drug working for MS is going to be people that have no other medical issues, right? Because if we start to get into populations that have more comorbidities, they have arthritis or all these age associated things, it becomes harder to like look specifically at is the MS drug making an impact or not. So that doesn't mean that we shouldn't do those studies. It's just a reason that from the pharma or from other funders, it's just a harder thing to do from a logistical and trial design standpoint. And then, we also worry, to your point, about like if you've had MS for 30 years, like how much of an impact can we make? Is the cat out of the bag as far as using these sorts of inflammatory treatments? The answer to that is we don't know, but I mean, I think what we see from the natural history is that, the studies for relapsing type medications are probably not going to do anything if you're not having relapses. But we may see with some of these newer medications like tolebrutinib that they may still be beneficial. The groups in those studies, like patients were older, they'd had to have MS for a much longer amount of time. So we'll see. But I think it certainly is a sort of an understudied area. Absolutely.
Yes. Would it be beneficial then for someone that has had MS for, 30 some, years to write into that story to a specific center so that they could take a look at stuff and say, hey, well, here's a combination or something maybe it would help.
Yeah. I think so. Advocacy things are important, right? So I think probably the biggest one, which we're in a bit of a challenging place for, is just looking at our funding to do science and clinical trials overall, just because the overall governmental funding situation has become very challenging, just with different economic realities and policy changes. I think those are probably the bigger drivers, that and things with our drug company partners, just because clinical trials are very, very expensive. So like even if we were to do a clinical trial like at the University of Colorado, using metformin, for example, where the drug itself is very inexpensive, that depending on how many patients we had, that would cost us hundreds of thousands to millions of dollars just because of all the work that is required. So those are probably the biggest barriers that we have, are just the money situation.
I'll jump in here too. If anyone is interested in sharing their story, the nonprofit, the Rocky Mountain MS Center, we do love to collect stories and also just know who is willing, so that when we have opportunities to share with researchers, share with Congress, share with other entities, we know who to call and say, hey, so-and-so is willing to talk about their experience, whether that's struggles with drug access, struggles with diversity in clinical trials, whatever it is. So if you are interested in sharing your story, you can always email us. My email address is just the word education@mscenter.org. And then I can start a conversation with you. So we are definitely always collecting those stories. And I would say keep that email address handy as well if you ever have symptom management questions, or you're like, hey, have you ever done an article or a video on such and such topic? I can send you all of those resources. So again, I'm Kelsey and my email address is education@mscenter.org. Yeah, I'll get you a card. I think we might have time for one more question, if we've got anyone with one more question. Perfect. We did a fantastic job today. So on that note, thank you guys for joining us. Thank you online. Thank you in person. And thank you, Dr. Wolf. There is an evaluation on your table. There's also, I put the link in the chat. Please do fill out that. I use that information to shape future events. And then, yeah, thank you all.